The hypercalcemia of primary hyperparathyroidism is because the parathyroid hormone is up despite a high calcium. That's why it's a disease. It's a failure of feedback inhibition. Most of it, like Cushing's, most of it, like Conn syndrome, most of it, like acromegaly, is from an adenoma. A small amount is from hyperplasia, and an even smaller amount is from malignancy, from cancer. And one of the ways you know it's an adenoma is that it's functional. Now, it's functional, and that is the adenoma makes a functional PTH. The hyperplasia makes a functional PTH. Parathyroid hormone cancer is actually rare. And then sometimes there's ectopic production, or the hypercalcemia comes with a parathyroid hormone-like particle. And every time there's an increased calcium or decreased phosphate, you can have a big polyuria from nephrogenic diabetes insipidus. Most people do not know that part of the reason that you have such a volume deficit in high calcium is that high calcium blocks the effect of ADH at the kidney tubule. High calcium causes a nephrogenic diabetes insipidus. Okay, hypercalcemia blocks the effect of ADH at the kidney tubule, at the collecting duct. So high calcium causes a nephrogenic diabetes insipidus, and that's why you get so volume depleted and dry in hyperparathyroidism. And this hypercalcemia inactivates that ADH. You get a massive volume deficit, and the higher the calcium, the harder it makes it to depolarize neural tissue. That's why you get lethargic and depressed. That's why you get weak. That's why you can't concentrate. That's why you get lethargic and sleepy. Because high calcium inhibits neural transmission. High calcium inhibits depolarization. The higher the calcium, the harder it is for anything to depolarize, and you get tired, lethargic, abdominal pain, and you can get some bone abnormalities because the parathyroid hormone is dissolving the bone. High calcium gives you a short QT. Low calcium gives you a long QT. High calcium gives you a short QT. Low calcium gives you a long QT. But when you have that hyperparathyroidism, it increases the alkaline phosphatase and osteocalcin, and this is a sign of bone turnover. And the cyclic AMP is because the parathyroid hormone activates 1,25-dihydroxy-D, and that puts cyclic AMP into the urine. Hydroxyproline comes out of the bone. Every time there's bone dissolution, every time there's bone destruction, you end up releasing hydroxyproline, which can be found in the urine as a sign of bone turnover. Hydroxyproline in the urine. So we can look at some of the cause of hypercalcemia, like lithium shifting the curve of parathyroid hormone, lithium causing some hypercalcemia and making it difficult. So what ends up happening is that also sarcoidosis. Sarcoidosis actually makes vitamin D. The granulomas themselves literally make vitamin D. Then when it says increased 1-alpha hydroxylase activity, that means that you're making vitamin D more active at the kidney. So sarcoid is a direct producer of vitamin D. Thyrotoxicosis does it because the extra thyroid hormone has extra turnover of protein everywhere. And thyrotoxicosis does it by the effect of thyroid hormone on bone, turns over everything. It's sort of like it's cold outside, let's burn the furniture to warm up the house. Milk alkali syndrome is kind of a passé idea. That's before we had proton pump inhibitors and H2 blockers. Milk alkali syndrome is from taking excess calcium and vitamin D. Thyrotoxicosis dissolves bone. Excess thyroid hormone dissolves bone. See, there's a lot of things that dissolve bone only under conditions of excess. Like, for instance, vitamin D itself. Vitamin D doesn't touch bone, but it does at excess. Lithium does it, thyrotoxicosis, milk alkali, and thiazides increase calcium reabsorption at the distal tubule in the same place that parathyroid hormone stimulates. So thiazides increase calcium absorption in the distal tubule. Now, high calcium levels with a normal or elevated parathyroid hormone is hyperparathyroidism. The same way if you have a high cortisol level and a high ACTH level, well, this is Cushing's disease. And if you have a high thyroid level and a high TSH, this is a TSH-producing tumor inside the pituitary. Well, this is a failure of feedback inhibition. And when you have a decreased, well, it's kind of funny, right? High calcium and high parathyroid must be hyperparathyroidism. And if it's a low parathyroid, it must be something else. Now, there's no medical therapy for parathyroid hormone. We have medical therapy to lower calcium. You give a lot of fluids because there's a nephrogenic diabetes insipidus. Bisphosphonates keeps the calcium in the bone, and calcitonin can be used therapeutically. But to get rid of the parathyroid hormone itself, the only therapy is surgical removal. But then again, it's the same with Cushing's syndrome, Conn syndrome, pheochromocytoma. The only way to get rid of the overproductions is with surgical removal. High volume fluids is done because the calcium causes both an osmotic diuresis and a massive nephrogenic diabetes insipidus. Bisphosphonates needs a couple of days to be effective, and while waiting for them to be effective, the fastest way is to give calcitonin. The fastest way to inhibit those osteoclasts is calcitonin. Calcitonin has an instant effect on osteoclast inhibition. Well, if hyperparathyroidism is simply an adenoma and occasionally hyperplasia, hypoparathyroidism, although there is a small number that's hereditary or autoimmune, meaning that your own antibodies are getting rid of your own parathyroids, what's a very common thing is simply they get removed surgically by accident in the process of you getting your thyroids removed or some damage to your thyroid. And what ends up happening is that if you have hypoparathyroidism, you have low calcium and high phosphate because parathyroid hormone should increase calcium and get rid of phosphate. And if you don't have parathyroid hormone, then you have a low calcium and a high phosphate. Parathyroid hormone should make phosphate excrete at the proximal, and calcium reabsorb at the distal. Should make phosphate excrete at the proximal tubule, and calcium absorb at the distal tubule. That's the effect of PTH. Low calcium makes muscles and nerves hyperexcitable. The lower the calcium, the easier it is for both muscles and nerves to depolarize. High calcium causes lethargy, constipation, obtundation. Low calcium causes seizures and hyperexcitability, muscle spasms, trostics on the facial nerve, trousseaus in the hand and the arm, trostics in the face, trousseaus in the arm, and all of it is about neural hyperexcitability. Low magnesium also causes hypoparathyroidism because magnesium is needed for parathyroid hormone release. Magnesium is a cofactor in parathyroid hormone release. If you don't have magnesium, parathyroid hormone is not released. Low calcium causes neural hyperexcitability. Pseudohypoparathyroidism is a G protein abnormality. It's a rare familial disorder, and the target tissues are resistant to parathyroid hormone simply because the G protein is missing. And you get the same symptoms as primary hypoparathyroidism, except that you've got a high parathyroid hormone. You got a high parathyroid hormone, but it doesn't work because there's a missing G protein in the receptor. So you have people with developmental defects and short fourth digit. Mental retardation, round head, and short fourth digit. Mental retardation, short fourth digit, round head. And it's a G protein abnormality, so the parathyroid hormone is up, but the effect is down. Parathyroid hormone level is up, but the effect is down. How come alkalosis lowers calcium? doesn't lower calcium, lowers the free calcium because it increases protein binding of free calcium. Transfusion doesn't lower the calcium, it lowers the free calcium because the anticoagulant in a blood transfusion is citrate. So if you have too much citrate, it lowers the free calcium. Alkalosis lowers the free calcium. Rhabdomyolysis decreases free calcium too because the damaged muscle will bind calcium in the sarcoplasmic reticulum for calcium. Damaged muscle binds the free calcium. So when you remove the layers of muscle covering, when you damage the walls of the muscle, you will end up having the sarcoplasmic reticulum for calcium will suck up that calcium and lowers the free level. And the tumor lysis does it because tumor lysis releases phosphate. And when tumor lysis releases phosphate, the phosphate binds the free calcium. Alkalosis, the free calcium goes on to the albumin. Transfusions lower the free calcium because of the citrate. And remember that anything that raises phosphate can decrease free calcium. That's one of the reasons that we treat with phosphate binders in chronic renal failure. Anything that makes you have a low vitamin D, whether it's nutritional, staying inside all winter long, will lower the calcium. Or, of course, there's nothing that lowers calcium like not having parathyroid glands. So alkalosis does it because hydrogen ions come off the albumin and free calcium goes on to the albumin. Alkalosis lowers the free calcium. It doesn't have to be alkalosis just from hyperventilation, but alkalosis from any kind, just that hyperventilation is the only way to do it acutely. That's why everybody who has a lot of transfusion needs to get calcium, because it's expected to have a low calcium with massive transfusion. So when we want to see what the defect is, we look at the calcium and the phosphate, and they should be changing in opposite directions. Now, primary disorder means hyperparathyroidism makes a high calcium, and the parathyroid hormone excretes phosphate. Okay. Well, hypoparathyroidism, the calcium should be low and the phosphate should be up. Now, in chronic renal failure, the reason that it's different is because when the kidneys are dead, you can't excrete phosphate. So the calcium goes low, but the phosphate accumulates as well, because dead kidneys can't excrete phosphate. Dead kidneys can't excrete phosphate. So when the kidneys are dead, you get a secondary hyperparathyroidism because the kidneys make 1,25-dihydroxy-D. If the kidneys are dead, they don't make 125. No 125, no vitamin D being activated. So you don't have a calcium. Oh, low calcium makes hyperparathyroidism. The parathyroid hormone takes the calcium and the phosphate out of the bones. The parathyroid hormone now takes the phosphate and the calcium out of the bones. But the calcium doesn't come to normal and the phosphate can't be excreted. So let's say it again. Dead kidneys lower the vitamin D. With no vitamin D, you can't absorb calcium and phosphate from the gut. So what ends up happening? Low vitamin D makes hyperparathyroidism. Hyperparathyroidism takes calcium and phosphate out of the bone. But you can't excrete the phosphate. So the phosphate level keeps building up. And then as the phosphate level builds up, it binds the calcium. So renal failure, everybody with renal failure that's on dialysis is on calcium and vitamin D. Everybody with renal failure is on phosphate binders. Vitamin D deficiency results in a secondary hyperparathyroidism because you either have a diet deficiency in vitamin D or you have dead kidneys resulting in low vitamin D, or no sunlight lowering vitamin D, or malabsorption of vitamin D because you can't absorb fat-soluble vitamins like celiac disease or chronic pancreatitis. And when you have these deficiencies, or even enzyme deficiencies, what ends up happening is that the parathyroid hormone goes up because it senses no vitamin D. It's very easy to be dietarily deficient in vitamin D, and it's very easy to stay inside and not get it from sunlight. Now, this low vitamin D and low calcium results in increase in parathyroid hormone. The increase in parathyroid hormone because there's a decrease in your calcium. Well, the decrease in calcium is associated with decreased phosphate. This is the major way you know that it's from low vitamin D, because if it was from low parathyroid hormone, well, first of all, you'd have a low parathyroid hormone level. But the other part is that hypoparathyroidism causes a high phosphate. Parathyroid hormone excretes phosphate. So if you had a low parathyroid hormone level, you should be retaining phosphate. So you lose bone mass because the parathyroid hormone is melting your bone. And you see a low 25-hydroxy-D. Which ones makes the 25? Where's the 25 made? 25 is made in the liver. 125 is made in the kidney. Vitamin D excess is very easy for people to get because you can't excrete vitamin D. Fat-soluble vitamins are easy to overdose on because you can't excrete them. Water-soluble vitamins like B and C, it's very hard to overdose on them, but fat-soluble vitamins can be overdosed. And the excess vitamin D raises plasma calcium, decreasing parathyroid hormone. And you have both a high calcium and high phosphate because the vitamin D is making you absorb both the phosphate and the calcium at the gut. The high vitamin D is making you absorb both calcium and phosphate because you're absorbing the calcium phosphate at the gut, at the GI tract. So you're absorbing both calcium and phosphate at the gut, and that's how you know it's vitamin D doing it, because calcium and phosphate are both up. And the excess vitamins make you melt bone because at excess amounts, it will dissolve bone. At normal levels, vitamin D does not touch bone. But at excess levels, the vitamin D will dissolve the bone. Okay, what do you call a starving vegetarian? A carnivore. Normally it wouldn't eat that bone, but when you're starving, it look very good. Well, predictive for secondary disorder means that the calcium and phosphate in the same direction is secondary. What that means is parathyroid hormone up or down, the calcium and the phosphate should go in opposite directions. Hyperparathyroidism, calcium should be up and phosphate should be down because parathyroid hormone absorbs and increases calcium and excretes phosphate. But if you have secondary disorders, they're both increased or decreased, the exception, of course, being renal failure. So secondary hyperparathyroidism is basically you have a low calcium for some reason, and it's making both the calcium because of low vitamin D. And low vitamin D means low calcium and phosphate. Now, in both the deficiency and excess of vitamin D, you have bone mass abnormalities. Remember that vitamin D normally doesn't touch the bone, but in vitamin D deficiency, you have secondary hyperparathyroidism that dissolves bone. In vitamin D excess, vitamin D will directly dissolve bone, which it normally wouldn't touch. So osteoporosis is a loss of bone, and by definition, the calcium and phosphate levels are normal. It's related to age, it's related to low estrogen, it's related to smoking, and your 2.5 standard deviations below the average. If you have an abnormality in your calcium or vitamin D level, it's not just osteoporosis. Osteopenia and osteoporosis are just by definition, is it 2.5 standard deviations or 1 to 2.5? But I want you to understand, you will never confuse osteoporosis and osteopenia with each other with a parathyroid hormone problem or vitamin D problem. Because vitamin D and parathyroid hormone problems always gives abnormality in calcium and phosphate, and osteoporosis never gives abnormalities in calcium and phosphate. Thyrotoxicosis can do it because it dissolves bone. Dissolves bone. thyroid hormone turns over protein. Bone is protein. Calcified bone is protein. And glucocorticoids activate osteoclasts. Glucocorticoids activate osteoclasts because it wants to turn the bone into free amino acids so that it can convert the amino acids into sugar, the glucocorticoids. The treatment for osteoporosis is bisphosphonates, which inhibit osteoclasts, for sure. Calcitonin is sometimes used because they inhibit osteoclasts too. And denosumab is a rankle inhibitor. It's a rankle inhibitor that's also indirectly inhibiting osteoclasts. Now, one of the things that's hard for people to understand is why teriparatide, which is a type of a PTH, why does teriparatide, if that's PTH, why is that forming bone? And that's because there's a paradoxical effect that when you have chronic exposure to parathyroid hormone, it actually inhibits osteoclasts. It's when it's short duration, it stimulates osteoclasts. When it's long duration chronic exposure, teriparatide, which is parathyroid hormone, will inhibit osteoclasts. Raloxifene is a selective estrogen receptor modifier. Raloxifene is like tamoxifen. Raloxifene is an anti-estrogen on breast cancer, but estrogen stimulatory on bone. And raloxifene and tamoxifen can both prevent bone loss, and this is one of the major reasons why aromatase inhibitors in breast cancer have major problems. You can say, hey, I cured your breast cancer. What happened? Well, I also had a hip fracture. I died. Ooh, well, we don't want to cure your breast cancer to have you die of a hip fracture. So that's why raloxifene and tamoxifen have certain advantages. They may not be as strong against the cancer, but they're even stronger on protecting your bone. Tamoxifen and raloxifene protect the bone. Teriparatide, which is artificial PTH, will work because over time it will stop the osteoclasts. Rickets used to be extremely common. Up until the 1940s and 50s, the milk supply didn't have vitamin D in it. And rickets was, particularly for urban poor children, was extremely common because they didn't have exposure to sunlight and they didn't have a diet that had enough things that had vitamin D in them. So consequently, rickets, which was a type of abnormal bone mineralization, was very, very common. Osteomalacia is a type of short, soft bone, but the difference is rickets is happening while you're growing, and osteomalacia happens after you're grown. They're both mineralization disorders, but rickets is, in a way, a kind of a pre-pubertal abnormality, and osteomalacia is post-pubertal softening. See you in the next section.